So, my name is Guralp Ceyhan. I'm from Munich. So it's a great honor and pleasure to be here. And I have to say sorry for the first. At first, I have to say sorry because since I'm a very busy surgeon, I did not manage to deliver my slides in time to Natalia. So sorry for that. So you only have got the English slides. So I know Natalia very well since I don't know how many years now. It's at least 7 years, and I have to say I don't know whether you all know that, but she is really working extremely hard in the European Pancreatic Club to represent your country, and she does this in a way which is, I think, exceptional, and for that I really want to thank her, and I think you all should thank her, because since then she is cited in the European Pancreatic Club. The Ukrainian is the most visible country within the European Pancreatic Club, and you should be proud of that. And this is very important for me first to say this. Now, coming to my talk, Professor Zenko has delivered you the first details also, which I will also come back during my talk. And I just want to give you briefly the problem we have within this organ. This is the pancreas, and I think within the pancreas we've got a lot of damage with all causes pain. We've got the obstruction of the common bile duct, of the duodenum, the obstruction of the pancreatic duct by stones within, and also, Natalia, the problem is also within stones which are not in the duct but are narrowing the duct. So this is the problem which we all also have. And there is a lot of necrosis, fibrosis, inflammation, which increases the inflammatory process within this organ, and also a lot of firing from inflamed nerves, which are leading to pancreatic neuropathic pain, which is a real severe pain. Now, this is, of course, then one of the main subjects we address when we want to go for therapy of chronic pancreatitis. And thanks to Professor Haas, that he said that neither the blockade or the stenting is not superior to surgery. He said this as a gastroenterologist, and I'm a surgeon, so it's very nice to hear that also these people also really recognize that the best option till now for the long life effect of therapy is within surgery, and I will come back to this during my talk. Now, still, we are on debate. What is the best therapy for our patients? And coming back maybe first on a study which maybe you all know is published by Can, who really, in a very nice fashion, investigated whether surgery or endoscopy is best in patients who have got painful obstructive chronic pancreatitis. And it was evident that after 2 years follow-up, the study had to stop because the surgical arm was so superior, so it was not ethical to go on with the study to see whether endoscopy or surgery is best. The patients with the surgery had less pain. They had majority of 75% who just only had partial pain. They were on better physical health, which is very important for the patients with chronic pancreatitis, because they can go back, work, and be socialized again. This is major importance. And they have to go less to hospital stay and have less re-interventions. So what happens, and seems to that the surgery was better than endoscopy. And when you follow this after 5 years longer, what happened with these patients? Some dropped off because they died or there were no follow-up data available. But still they had less pain, not significant, but overwhelming 80% partial pain reduction. And which is very important is less still re-interventions needed in the surgical arm. 5% versus nearly 70% in the endoscopy arm. So this means all these patients were still under medical treatment and also interventional treatment. And at the end, 50% of these patients who just got endoscopy needed operations. So at the end, they come back to the surgeon again. So that seems that the surgery is more efficient than endoscopy when long time treatment, successful treatment is concerned. This was also verified in a recent Cochrane database systematic review, where clearly the early surgical drainage is much more effective than the endoscopic therapy in patients with obstructive and chronic pancreatitis. Now, the problem is, what means early? I want to demonstrate this problem on a case. Now, we have got a patient who's 43 years old, long-term alcohol abuse, bile duct obstruction. We know the story since 2001, just remember. But after 2005, he started to go on medical treatment with several stent replacements a year, several stent occlusions, where he just again have to reintervene. 2008, he has one of the major problems with portal vein thrombosis, then got a metal stent, then again a plastic stent, in the metal stent, laser therapy within the duct, and then what he developed was a pyloric stenosis, like a patient with cancer. Now, this is the picture of this patient. And what you can see here, the portal vein is occluded. You have got a massive inflammatory process. You've got collaterals, which is also very dangerous for the operation. Collaterals, the venous collaterals, so it means the portal hypertension. And you've got a situation here where you can see that you have an inflammatory mass around the ligament. And so you don't see any planes anymore. And this was the problem also when these patients, after, maybe I come back, 11 years of story of chronic pancreatitis came to our department, and then the problem was, we did a laparotomy, but the patient was not resectable because of the massive tumor mass. Was just like a massive tumor, and which you could not move. And we had to do an oncological double bypass in a patient who does not have got a malignant disease. This is the problem we have. Now, up to now, we have no data available whether we can consider a certain time point for surgery. So there's no trials going on that. We have got 2 retrospective data, both from Germany, where they just identified around 400 patients that patients have less success after surgery when the history of chronic pancreatitis goes longer than 3 years. And this was the indication also for these authors that the patient should go earlier for surgery to avoid pain persistence. In Boston, retrospective analysis of 66 patients, this was a similar time point here, 60 to 26 months. And when you compare the patients who were operated 26 months with history, or less than 26 months, or more than 26 months, then you could see that they had more opioid use, and that the pain-free situation was clearly in advance for the patients who had less time between diagnosis and surgery. So that really here the message was early surgery leads to less pain and opioid use. In a similar study where the colleagues from the Netherlands investigated in their country around 300 patients, and that they also have found nearly exactly the same, that the patients who were pain-free, these were the patients who reported to have less pain than 3 years, who did not use prior to operation opioids, and had less than 5 endoscopic treatments. So that means that early surgery, less than 3 years, less interventions, leads to a significantly better outcome. And on this, there were now a systematic review, auch recently published by the Harvard group, and clearly again the same. early surgery leads to better pain outcome. But we still do not know what means early. And that's the reason why, again, the Netherlands, I mean, the Dutch friends are very busy and good in doing good studies. And they now initiated a study which is already running, and it's the so-called ESCAPE trial. And the ESCAPE trial defines early surgery versus optimal current step-up practice for chronic pancreatitis. This means the patients are defined after they develop a disease with progression, with dilation of the pancreatic duct over 5 centimeters, when they start to get opioids within the progression and have got frequent flare-ups. This means frequent attacks of the pancreatitis. And they are randomized then in either medical control or just directly surgery. So the study is running and we are eager to get this data. But till then, the conclusion on the timing of surgery should be, don't wait longer than 3 years to consult your surgeon. When opioids are needed and you have to give opioids to your patients to have him pain-free, consult your surgeon prior. Maybe he can help. And don't wait for complications to consult your surgeon, since it will also lead to major, intra, and also perioperative complications. Because you can imagine a patient with portal hypertension, etc., is not easy to operate. And then you have got the morbidity, where all the people are talking about. But when you operate them early, this morbidity is not present. Now, what are the aims of the surgical therapy when we do the surgery? It's of course the pain relief, the removal of the stones and the stenosis, and the reconstruction of the passage, relief of the cysts, which is also major importance, and of course clarify uncertain dignity, where I also do fully agree with Professor Messer, which I think is of minor importance, but still an issue. Here we've got the surgical procedures which we can do with chronic pancreatitis. These are the drainage procedures, the resection procedures, and we saw some very nice slides also from Professor Zenko, and where he just directly introduced you this. This is the Pistou operation, where just longitudinally the pancreatic duct is open to relief of pancreatic pseudocysts or stones, or even more, let's say, an advanced way to open up the entire pancreas in a Partington-Rochelle way. So this is a case which I just operated, a 40-year-old female. She has got deep and constant pain in the epigastric area due to chronic pancreatitis, and this history goes back 7 years of conservative treatment. She has got at least 3 to 4 attacks which hospitalize her every year, and she had several attempts of stenting and lithotripsy and chronic analgesic consumption. In the CT scan, you see the problem. The problem is quite clear, because here you have got a big stone in the pancreatic duct. Here, a consecutive dilation of the pancreatic duct with also formation of a pseudocyst. And what happens also in this situation is that the remaining pancreas, because waiting 7 years damages. I mean, you are waiting, trying to get help the patients, but within that time you are destroying the remnant pancreas, because there's no pancreas left anymore due to the chronic hypertension during the duct. So what we did is a similar operation what you also saw before. Here is the longitudinal opening of the duct. You can see it opens like a book because of the hypertension, and then you can easily put a jejunal loop on it, make the anastomosis, so that you have a wide drainage, so that you have got maybe the chance that somehow the remaining pancreas recovers, but due to the loss of the hypertension during the duct, you are also reducing the risk that new stones develop. This is also of very major importance, I think, within this. We also heard a lot of in the prior talk that when you have got an inflammatory mass, stones in the head, you can go for Whipple. And this was done, I think, till the 70s and 80s, especially in Europe. But then this guy came, and this is Professor Beger. And Professor Bega, he is now 18 years old, and 2 weeks ago, he's still active. I saw him on a congress. And when he was 36 years old, he invented this operation because his idea was that we have got a problem in the head. And why resect a healthy organ completely when it's not a malignant disease? And he wants to get rid of the firing process, which is somehow the burning area of the pancreas. And this was the head. And he said, cutting out the pancreas would help. And at that time, of course, there were no fry procedures or whatever. He operated like he operated a Whipple. So he transected the pancreas. So he had two sides of opening of the pancreas and also of the pancreatic duct. Here on the left, like you usually do when you do a Whipple, and here the entire pancreatic head. And then reconstructed very easily with a jejunal loop. Now, when you can see, and these are data from nearly 2000 and beginning of the century, and I heard something about Dr. Haas fearing about mortality, and at that time, and I would say mortality of 0.8. I don't know the mortality of ERCP, but maybe it's the same. So I think you can do these operations when you do that in a high volume center in a very good way. And the results were astonishing. So he had complete penetration to 80%. Endocrine function improved 11%, which is, I think, not good, but it's also not it's understandable because the organ is damaged. But most important thing is the patients were active. They could be rehabilitated, they could socialize, and their quality of life increased. Another procedure which you also saw today is the fry procedure. This is some combination of the Bestow or Particle Rochelle operation with the Vega operation, where you core out, let's say cautiously, the pancreatic duct and open longitudinally the entire pancreatic duct for drainage, and also reconstruct this with a jejunostomy. And there is a lot of evidence. Although we are surgeons, we are doing good randomized control trials on this matter, whether Bega, Fry, Whipple, whatever, is superior. And I want to introduce you the most important ones. Here, the Whipple procedure was compared to the Bega procedure. And what you can see clearly is that with the Whipple procedure, the patients had still pain, 30%. They need enzyme substitution, so exocrine insufficiency was a real matter. And they did not gain weight as they had with the duodenum preserving procedure. When you do it with the pylorus preserving, the other one was the classical, then the difference were not great, but still the weight gain was greater in the Bega, and the pain relief was also greater in the bigger arm. And when you compared the Fry procedure, you had nearly the same results, with increased quality of life, with the organ preserving procedure, and also decreased morbidity in the patients who had more organ preserved. And when you compare both organ preserved in a randomized controlled trial, there was no difference at all. The late mortality was simply the quality of life, the pain, and there was also no difference in exocrine or endocrine function. So this means these are two procedures which are equal. Now, at that time, so end of 1990, 95, we knew that Bega and Fry was better than the Whipple operation, but we knew that Bega was equal to Fry. So the mentee of Professor Bega, Professor Büchler, then came to the idea, why not combine these two winners within one operation? And then he introduced the burn modification of the duodenum preserving head resection, where he does not transect the pancreas, widely opens the pancreatic head, so that we only have one anastomosis to make, where in the Bega you've got two anastomoses to make. And of course, what happens? Then there is a challenge between the mentor and the mentee, and there was a study first published in Königer and then by Kleiber et al. As a long-term follow-up, where it was in a prospective randomized controlled way compared whether the Beger or the burn modifications are best for our patients. And in 2-year follow-up, it was clearly that the burn technique was technically simpler, which is I think very important, so that it can be widely used. It is of course shorter because you are doing one anastomosis less, and it brings also the patients faster to home, so that at least with this first, after 2 years follow-up, they could show that the Beger modification is as equivalent as the Beger. And after 10-year follow-up, there were really no differences in patient-relevant outcome parameters. More than half of the patients in both arms were completely free of pain, and in both arms improved quality of life. So at the end, the mentee is as good as the mentor. So it means that both procedures are equal and both procedures give up the good result. Now, what are the new data? New data is comparing again the duodenum preserving head resections with the pylorus preserving pancreatidonectomy, so Whipple procedure. And here, in a recent meta-analysis, still the organ preserving wins with increased quality of life, faster professional rehabilitation, better exocrine insufficiency, and less stay of length during the hospitalization. Now, also Professor Keck, who's also here, has done nice randomized trials regarding disease with comparing the duodenum preserving resection with the Whipple procedure. Here, the operating time was better with the duodenum preserving, but interestingly, they didn't find any difference with regard to morbidity or post-operative complications, quality of life, and also especially pain. So the new data show that they are somehow equal, but maybe a little bit favor to the duodenum preserving procedure. And you compare this Fry versus the Whipple operation with a recent randomized control trial, then again you see the superiority over the quality of life and overall survival in the patients who has got duodenum preserving resections than where the duodenum is resected. But interestingly, again, in the newer studies, the pain was not different. Other the success for the pain. Success was there, but it was not different between these two procedures. Another study from Professor Keck is who evaluated the perioperative long-term results, again comparing the two duodenum preserving resections, and could demonstrate that the overall morbidity and also surgery-related perioperative morbidity were similar, with a favor to the Fry procedure. But again here, between these two preserving resections, no real difference was evident. So at the end, we can say that the Beger and the Fry procedure are better than the Whipple procedure. But with the new data, maybe, of when regarding pain, not as good as we believed, but these are still under debate. But what we for sure know is when you want to go for a duodenum preserving, as an organ preserving head resection, then it does not matter whether you do a Beger, Fry, or Bern-Büchler operation. So when I sum up my talk, it's clearly that surgery for chronic pancreatitis is a safe procedure. We don't have to fear that operation. We can do it safely. We can do it with low morbidity and low mortality. And we can tailor the problem. This means we can adjust the tools we have as surgeons for the patients who has got it. Because when you have a patient who has got portal hypertension due to the closure of the mesenteric vein or the portal vein, when you do a Fry, you will not help the patient because you have to free the portal vein. It has to breathe again, and this you can only achieve with the Beger operations, not as good with the burn or with the Fry procedure. And with this all, we believe that and demonstrate that we can improve the quality of life of these patients. So, early timing of surgical therapy is really crucial for the outcome. This is very important. Surely the surgery should be considered early once symptoms are unambiguous and opioids are needed. This should be an alarm. And when you do an organ-preserving surgical method, then it doesn't matter what you do. You should adapt to that of the complications you have with pancreatitis, what you see during the operation, and also the individual experience of the surgeon, because the surgeon has to feel comfortable with that, what he's doing. And thank you for your attention, and I'm open for your questions.